So I'm going to start while they're getting ready so we can start going with the questions right off the bat. So one question here, which is something we haven't talked about very much, is pain. And there's one question here that says, how or why can one have numb and painful feet, I assume, and painful shooting, stabbing, burning pains, etc. So the pain in CMT is, as you all know, is multifactorial. Some of it has to do with things that Dr. Pfeffer works on, which is the construction of your feet and the pressure you're putting on certain aspects. So those calluses can be painful, the pressure areas can be painful, the distortion of the bones of the foot can become painful, and things like knees and ankles can become painful from arthritic aspects because of the mechanics of your walking. Some people also get the burning, stabbing pains, which is what we call neuropathic pain. And different forms of CMT have more or less of that pain. And that neuropathic pain is also somewhat complicated. But the reasons to differentiate them is because the things that treat this pain can be different. Neuropathic pain medicines, like you've heard of Lyrica and gabapentin and Cymbalta and Elavil, there's a bunch of them, work on neuropathic pain but don't do a great job on arthritic pains or bony pain. Other things work better for the bony pain and the joint pains. So it is an important issue and needs to be dealt with clinically. The causes of the pain is more difficult. Anyone else have any thoughts or comments about pain? Okay. So Tara, why don't I ask you to respond to one and then we'll move on.
Okay, so the question I have here is, will a clinical study be done here to identify genetic components? And the answer to that is yes. We're part of this CMT consortium that Dr. Lewis has been talking about. So for patients that don't have an identified genetic component to their CMT yet, we are collecting samples that are being included in the CMT consortium data, where we're pooling together samples from patients with all types of CMT and other neuropathies, trying to identify the genetic cause and helping to analyze all these variants, because we'll have samples from people with all types that we could look at.
Rudy?
The question was asked, can braces be used to prevent the foot from deforming, especially in children? I don't think it could be used to prevent long-term. It could halt, but I think if you get to a point where the foot could be surgically corrected, that is optimal, I think, in the long run. I don't know if Dr. Pfeffer has any input on that. But bracing are more to give you function. If you have the choice to have surgery or treat it orthotically, it's strictly up to you, but I think the surgical intervention, if it yields the results that Dr. Pfeffer has shown to get, I think that's a better option.
Glenn, any comments on that? And you may have to then go on to your question.
It follows, one of the questions I have here is, how do you know when it's right to have surgery? And if you don't need it, you wouldn't have the surgery. But the question is, who needs it? And how do you let yourself truly decide whether you need it or not? You know, it's so often with any foot problem, I'm talking to someone in the office, right, and there's a guy sitting there, and he goes, I'm doing really okay. And his wife is sitting there, right, whether he has CMT or not. And she interrupts and says, excuse me, darling, I have to interrupt for a minute. Dr. Pfeffer, we used to love to walk the dog together. When's the time we did that, Bill? Now all he cares about is a big screen TV. Remember how we used to love to go dancing, darling? And then he goes, well, yeah, I guess you're right, So I can say this. Bethany and I was talking in the back to Bethany and some others, but I've never had a major complication with a foot surgery. So, after 27 years, I'm pretty bullish. I've not had to amputate someone's leg. I've had some people with CMT I've operated on, and their disease has progressed. And I've often wondered when it happened twice, and I thought, God, did my surgery somehow precipitate that? But what's going to happen? It's really hard to be worse if you're starting from a C-. So surgery is good for a foot that's deformed and doesn't sit flat on the ground, period. And I can honestly say, I don't think if there's someone out there, let me know, but I don't think I've ever made anybody worse. So what's to be afraid of? What's to be afraid is to limp around the rest of your life with a foot that's not flat, and that as you get older, it leads to a hip fracture. So I have but again, let me just make it clear, and Rich alluded to this, I have a very focused group of patients I see. It's a very certain group that helps with this. I can't really help someone with extensive paralysis. I won't keep going on. It says here, is it possible to walk without a brace after a tendon transfer? Sure, if what muscles you're transferring are strong enough to let your foot move without a brace. So the key is the surgeon has to be very realistic about what the end point is of the surgery and what's obtainable. And it's a long discussion. Anyway, I won't keep going about that.
Bethany, I know you don't have any questions, but do you have any comments or anything you would like to?
You had surgery. Did it work or not work?
It doesn't have to be about
Sure,
that question.
I can
just
comment
about
on
life in general.
Dr. Pfeffer's questions of when to have surgery. And looking back, I'm almost glad that things got as bad as they did, because otherwise I would have put off surgery for as long as possible, right? Maybe till I was 40 or 50 and I had no other option. And I would have gone through all those years struggling just to get by. Whereas now, I mean, I didn't go into the results, but now I can walk without zero pain. Obviously, I can walk up to 7 miles on a really good day. And it's been really life-changing, but it's also an incredibly physically challenging experience to go through and an incredibly emotionally challenging experience to go through. So I think everyone needs to ask themselves if they're at that point where they feel that it's worth it for them, and that they'll be able to sort of get through that process and take care of themselves in terms of recovery.
I just operated on a young woman. It was so sad. Maybe a month ago, and she had one of the worst CMT deformities on both feet, and she's walking along like this. I mean, you know these people, and she can't even walk a half a block. And she said, "Well, I think I can do the surgery now because I have a support group. I'm in a halfway house for drug addiction in Malibu." And then she comes back the week before the surgery. She goes, "Well, as soon as I have the surgery, they're going to throw me out because I can't be there anymore." So her problem was getting support to get through all this. And the mother, who she hadn't talked to for 5 or 6 years, came home to help. I'm not sure how they're doing, but mom's helping anyway, and she got through it.
Bob?
Sorry. Sure. Actually, someone came to me at the break and asked me a similar question, and so maybe we can expound on it, and that is that with clubfoot, there are non-surgical options, and I think this is maybe what that question was about, in that can there be bracing things that stop these deformities from happening if they were done early? And that was the question I thought that was a great question, so and I'm going to throw it back to you because I don't know the answer. I mean, is that something that's been considered by the orthopedic community for CMT?
No, I've not seen that. Of course, with clubfoot, you're born with the contracted deformity, and you'll place the foot in casts and gradually bring it out, and then perhaps keep it in a brace for a while. But if you catch it young enough, I mean, we're talking about after birth, then the deformity doesn't recur. You'd have to have the CMT is a much more dynamic problem than I think the static problem of club feet. So it would be very hard to be in a brace early on, but it's a fascinating idea. But the thing is, you're not going to wear the brace when you're sleeping. You're not going to wear the brace probably all the time when you're walking barefoot. So that the deformity, because of the muscle imbalance, will probably progress. But theoretically, absolutely. I think if you took a child who you knew was going to have CMT and knew who was going to have a deformity, we don't know who's going to have the deformity, and put it in a brace, you would stop the deformity from happening. Absolutely.
Yeah.
I think, if I can add, part of it also is a kid that you're trying to prevent the progression, or at least the deformity, they probably may not even have one yet. You're just anticipating it because they are CMT. But that kid can run already. He can do everything all the other kids are doing for the most part, depending on the severity. And to tell them they have to wear a brace just to correct their foot for 10 years down the road, good luck, I think. I don't know that I would do that.
Yeah, so, sure. So I guess the first question I had was, what evidence do we have that reintroduced Schwann cells will replace affected CMT Schwann cells? So that's a good question, and it's one that comes up often in stem cell transplantation therapy settings, whether it be to try and replace muscle or anything. It turns out that cells tend to incorporate into tissues very well when there's damage to the tissue. So if you were to take a person who doesn't have CMT and squirt extra cells in there, the cells would not do very well. They generally are just, they sort of die or just sit there. But in muscle that's been damaged, if you inject muscle stem cells, they tend to make new muscle. And so the logic is that in nerves that are damaged, like CMT nerves, that it's actually the right type of environment to get them to take. And in fact, from that same concept, just for experimental purposes, we first usually have to, in an animal model, damage the myelin to get the cells to go in and to take. So that's the evidence that we have. And you know, as I said, it's really just starting to be asked right now. We're doing some of the first experiments that we know of. So.
Gina or Pat, I think you have a...
Sure, I have a question. I don't know if I need a microphone or not. I'm pretty loud. My question is about the Los Angeles Area Support and Action Group, and it doesn't necessarily say if it's Steve Fox in Los Angeles or Alani Price in South Los Angeles, but it asks if they could exchange emails and Facebook, and it's also asking about the specific meeting location. So my response to that is, you know, what you can do is see both support group facilitators, but get on the CMTA's website, join the support groups. All of the support groups are listed, and that is a fantastic way to stay in contact with the facilitators, get updates on meeting locations, and yes, by all means, Facebook, talk to Steve, talk to Alani, but go to the support group meetings. You're going to get to meet people personally, and you're going to be able to exchange phone numbers and email addresses. And it also asks about fundraising, which I like. Talk to the facilitator. Bring up your ideas that you may have about fundraising as far as the group goes. And then I always work with the facilitators on making that fundraiser happen. So my response is to join the support groups online and, you know, contact each other definitely through Facebook. Pat?
So I've got the easy ones here. Will access to copies of the graphics or text screens be provided to us online? So we've recorded everything here. It will be on the website, I'm sure, after editing, so everyone will have access to it, and the CMT community can have access to it also. Same question. Hold on. When will Stanford hold its conference in 2014? Booked September 27th this year, September 27th, and I think Carly's here, and Doc Day is here also, so we should have a great lineup there also, and even more updates on the research. Can I go through them all here?
We'll go around. Okay.
My question was, and we hear this a lot, not just from CMT patients, but from CVA stroke patients and others who require orthotic intervention, but why do so many combat amputees with artificial lower legs seem to walk better and have more physical activities than those of us with CMT who are using braces? The easy answer is these are 18 to push 40 maybe athletes, basically, who have lost their limbs in a traumatic accident, who don't have a progressive neurologic disease. So they go from being able to jump out of trucks and do, 100 push-ups at a time to being able to do that the next, well, not the next day, but certainly within a reasonable amount of time with a prosthesis. And the biomechanics of trying to control a triplanar deformity in somebody who has a neuromuscular disease is a lot more difficult than fitting a prosthesis and aligning it mechanically to still accommodate those triplanar issues. And the technology in prosthetics now which Rudy alluded to as well this morning, has now been embraced by the orthotic community in terms of replacing some of these plastic braces with dynamic carbon fiber and epoxy devices, as you see out in the foyer, is getting there, but you can't replace the nerve with a brace. But they look pretty good running.
Okay, I'm going to kind of lump a few questions together here. There's one about does CMT affect the heart, one about the vocal cords, one about internal organs, one about vision, and one about breathing. So these are all good questions that have to do with, does CMT involve more than just your hands and your feet and your arms and your legs? So I'm going to answer them, and anyone else can please chime in on this. Certain forms of CMT may involve some other things. Vision can be involved in various sundry ways in CMT2A and some of the other ones. Vocal cord, there's a form that had been identified as CMT with vocal cord paralysis. I think that's still 2C. I never know the nomenclature. But actually that also can be seen in other forms of CMT than just the 2C. Internal organs is a harder question. There probably are some forms that I just don't think about too much. Bob or Carly? Bob knows all these, the 73 different ones, better than I do. Any that would be?
I think the only chance would be autonomic involvement and innervation of those organs, the gut, the heart, and so forth.
Right. Heart is not one that typically tends to be involved. The one that's most concerning is breathing. So I thought I'd spend a little time on the breathing one. Clearly, and there's another question about scoliosis, which also plays into this. Some forms of CMT, people with CMT do have scoliosis. People who have the more severe forms of CMT, the Desjardins-Sotas type phenotypes where walking did not really occur at the right age and may not have occurred at all. Scoliosis comes in, and when you have a curvature of the spine, it can affect your breathing. The breathing muscles are innervated by nerves, and you use your intercostal muscles and the muscles between your ribs. You use your diaphragm. Those are all innervated muscles. And so breathing can be affected to some extent in CMT, but in general, it doesn't usually become a major issue unless you have more severe forms of CMT. So when muscles cause breathing problems, it's not a problem of oxygenation. It's a problem of the strength of your breathing, which usually causes problems in carbon dioxide. Very similar to the problems Bob and I deal with in our ALS patients, but it happens almost all the time in ALS and in a much more severe way. So the treatments for neuromuscular causes of breathing problems is using BiPAP. It's basically, CPAP is what people use for sleep apnea. That's continuous positive airway pressure. It works very well and allows me to sleep with my wife because otherwise she throws me in the other room. BiPAP gives you pressure both in inspiration and expiration and is very helpful in neuromuscular disease. It is the most important thing we do with patients with ALS, and when people need it, they need it. So that is basically where, in severe forms, we have a number of patients who've had CPAP. Someone asked me at the break about sleep in CMT. It can be an issue. I think it's being investigated to some extent. Carly, you may have some knowledge about that I don't have. But it would be reasonable, and it's something we'll bring up with the consortium about questionnaires on sleep with our patients. Because I think sleep, and it gets tricky because sleep is partly related to breathing, so we do need to understand that. So that's kind of a quick and short
Can I chime in real quick there?
Yeah.
You know, it was brought up, and we're sort of humbled all the time by thinking we know that other organs being involved. And an example came up because somebody asked me here at this conference as well, I have kidney problems, and is that related? And if just a few years ago we would have said no, but we found a gene that actually causes kidney failure as well as CMT. And so I have a hard time answering that question when patients come in anymore because I'm never sure. It's possible that either the same gene defect does affect another organ system, or they're one of the few people who have a known gene defect, but it does affect another organ system. So we try to keep an open mind when people ask us that, and at the same time not blame everything on CMT, which is the other side of the coin that people have experienced with physicians who don't usually see it, is just, oh, something's wrong, and they just kind of say that must be that. So.
Yeah, I think that the take-home point is they always might be, and your CMT physician certainly should at least think about it and look into it. But for you, if you're having a problem with your heart, you better take care of your heart, irrespective of CMT. Don't assume it's a CMT and not take care of it. And that's true with any other symptom you have. So people sometimes hide from their other problems and try to say it's always the CMT when it may not be. So you do want to deal with your problems directly, and if it turns out to be related to CMT, then we'll be happy to work with your physicians, your hematologist or oncologist or GI doctor to kind of deal with those things.
So I got a couple of questions about inheritance, so I'm going to try to answer them both at the same time. The one is asking, is CMT, and I think it's 1A, that's what the question is, does it require a gene from one parent or both, and why does one child get it, but not necessarily other siblings with the same parents? And so the answer to this is that it either requires the gene from one parent who would then presumably be affected as well. So you have mother and father, let's just say that the mother is affected, and then there's a 50-50 chance of each child getting affected and inheriting that gene from the mother. So it's a flip of the coin each time. You could end up with all the children affected, none of the children affected, or just one. But it doesn't have to be inherited from either parent, and that's what we've seen, and as some people here today have talked about that, where they're the first person in their family to be affected, and there's no family history. Neither parent has a mutation in any of the CMT genes. It wasn't passed on. It just occurred as a new spontaneous gene change in that person. And that's something that occurs in all different types of genetic conditions. It happens at the time of conception. There's nothing that anyone could do that causes it to happen or prevent it from happening. It just occurs at random and sporadic. So I hope that that answers those questions. And then someone who said, I have CMT, my brother and two sisters do not. Can they be carriers, or must they present in order to pass the gene on? And it depends on what type of CMT we're talking about. If it's CMT 1A, then it's the dominant inheritance, and you have the affected people and the people who are unaffected. There's no risk of them having the disease or passing it on. But if we're talking about some of the other types, the inheritance patterns vary. So I'm not sure what type the person's referring to here.
Okay. Glenn? I think we're...
All these questions got me thinking. The only thing I would follow up on is what you were saying, and a question here about with surgery, is balance improved? I think not enough talk of surgery. You understand where I'm coming from on that. But the one issue of balance and prophylaxis, and does a brace help? I don't really know. This is my first wonderful exposure to the CMTA. I mean, I've looked at the websites, I've met patients, but I don't know the depth of what's available at the organization. I look forward to learning more about it. But if someone has the genetic predisposition to developing CMT, or if someone has a diagnosis of CMT at any age, there would be no question that appropriate stretching exercises and balance exercises would help. How much it would help, I have no idea. But if your peroneus brevis is going to probably get weak, how could it not help to do exercises to keep those remaining muscle fibers strong? If we know that everyone in this room who has CMT of any form has balance problems, how can it not help when you first learn to that diagnosis, or if a child carries the genetic expression for that diagnosis, how could it not help to improve what would normally be inevitable? So it's something I'd certainly like to pursue on well, let me ask that question. I mean, are there programs that you all have for just those issues of specific therapy and specific balance programs for the person with the diagnosis who's not really yet developed the diagnosis? Not so much from a hereditary point of view, but from a CMTA point of view, or Rich or Bob. I mean, is that out, or I'd ask you, is that out there? Do you all know when you go and what to do? We had a fine talk from Dawn, but anyway, there's work to be done in that area, and I think there are just sort of pockets of knowledge around the country about that. So that was the answer to this question: is your balance improved after surgery? And sure, it might be, but keep your balance up when you make the diagnosis or when you have the diagnosis, and have very specific therapy, both prophylactic and once you develop the problem, to keep it up. I mean, does that make sense from your point of view, having gone through it or going through it?
My balance was definitely improved having surgery, which wasn't a benefit that I really anticipated, which I guess can be explained because now I'm standing on the bottoms of my feet instead of just the sides of my feet, right? So it makes sense. I'm definitely more stable, and a lot of things like getting upstairs became dramatically easier.
Are there specific exercise programs, specific CMT directed exercise program that you're participating in on a daily basis? Just like, maybe I try to work on the stair climber or someone else is lifting weights. Has anyone ever gone over with you a peroneus brevis tibialis anterior proprioception balance program? What?
No,
Why?
the only thing I can tell you is when Carly and I, and
No.
I don't remember whether it was at the consortium meeting in London, there is certainly a physical therapy, exercise, research program being developed at Queen Square that's going to be utilized or worked on, at least in some of the centers in the Rare Disease Consortium. I don't know where that is in its development, but it was part of the things that we talked about. So those questions are being asked. Whether that specific question is part of it, I don't know. But
Good.
You're right that we do need to get a better handle on, what activities, what exercise, what physical therapy, what stretching, what's the right way to do this, and how much, what type, how long, all that needs to be done. I guess I hit a nerve.
No, but and not that hard to do, because a lot of it's just common sense. To understand the genetics here is sometimes not such common sense. But to do this, you could actually just ask the people in the room with CMT what's your problems, and you can develop a program.
But as you know, each of your feet are slightly different. Each of your strength aspects are different. Some people have weakness in the quadriceps and proximal muscles, some don't.
Yeah.
And so no matter what, your exercise program, your therapy is still going to need to be tailored to you personally. It will probably never be one type of therapy for all.
Absolutely.
And Dr. Pfeffer, if you have some extra time, you could develop some of this stuff for us.
Yeah. Early on, it's interesting. You've seen in national news issues of dance therapy, and I don't know. I worked with Dancing of the Stars and some of these programs here, and I often thought for a specific foot type, there'd be a specific dance that someone would do that would keep those muscles. No, I'm completely serious. There's no question that early on, before your CMT, God forbid, is disabling, that doing a tango with your 14-year-old is going to keep certain muscles stronger. So it could be fun. Anyway, I'll do it with you. All right, anyway. But there's
just because one of the other questions had to do with, that was brought up earlier about, I can't pronounce it, but alternative therapies, specialized exercises, and is there research going on? there is, as far as I know, not specifically for CMT.
We should work on that.
But if someone has that expertise and feels it's appropriate for CMT, then I think we would be happy to look into it to see if there's some way that we can explore whether there's a way to determine whether it has a particular benefit in this disorder. So there is interest. I think we all believe that there's lots of different approaches. We don't have all the answers. And so if anyone has a good idea, I think bring it to people's attention and we'll see what we can do.
So I'm just going to add my 2 cents. I said my piece on physical activity, but I can tell you, maybe it's the engineer in me, but I don't think it's rocket science to believe that if you keep your weight down and you eat properly and you feed your body properly and you stretch without doing a very expensive study, that's going to benefit every CMT person or any person, quite frankly. And I think, you all see a lot of patients, and I travel the country and I've seen a lot of support and action groups, and it strikes me that a lot of ancillary problems are not CMT related, but weight related, or using CMT as an excuse for not doing any activity. And I can counter probably any one of you who challenge me that there's going to be an activity that someone can do. So, from my standpoint, a lot of it's customizable, like everyone's here said. I know there's one going on in the UK on a study currently, and I don't know what the status is. I think it was a 2-year study. But there's a lot of things you all can do that are just common sense, and sometimes in this country and in the world, I think we've lost our common sense sometimes. So.
If I just briefly, so here's a tip. If you have CMT and you haven't gotten a bad fixed toe deformity, or you know someone who's got it, especially a young person, every night, just take each toe and bend it down. 30 seconds for each one, and you will never get the fixed deformity that needs surgery, in my opinion. No study done, but sometimes you don't have to study something to know it's true.
So the question is,
Yeah,
who has CMT1?
We have enough people in the audience.
And who has CMT2?
Yeah,
That looks to be about the
that's right.
percentage as we would expect it.
Who doesn't know?
Yeah, who doesn't know, right?
Not taking a test.
That's the important question.
Okay.
That's,
So I don't know if that helps, but okay.
I was gonna
Why
say,
don't we, we're going to move on because I know there are a number of research questions that
Sure.
went to Bob, so I
The
want
dancing stuff sounds complicated. I'm going to stick to the Schwann cells, or the stem cells. So I actually have gotten this question a lot, so even just walking around, it says, in the future, will banking of baby stem cell cord blood be beneficial in slowing, stopping progression of CMT? If so, when? Do we think that will be widely used? So it kind of brings out what is baby stem cell cord blood, cord blood stem cells. And they're really blood stem cells. They're not an embryonic stem cell like we talked about, where you sort of can become any type of tissue. It's possible that we can drive them back, just like we drive skin cells back and then forward again. But they would have to have that done in order to be useful for a nerve transplant or a brain transplant, or depending on what tissue. Now, if you were going to use them for a blood disorder, they might be more directly useful. So the answer is, really at this point, we've not used them for anything. Everybody who's banking them is banking them on the hope that they'll be useful for something. The answer becomes sort of personal then. Do people want to pay the $100 a year, or however it usually is, to have that as a possible insurance policy? If you don't, I wouldn't worry about it that much, because as I said, we're really developing the technology to take any cell, even an 80-year-old cell, and reprogram it back to an earlier stage so that it doesn't have to be from a baby. So that's pretty much the answer right now. And the reality is, nobody knows, because it's not even currently being used for anything. And we'll look back at this someday as either it was a big scam and everybody paid $100 and a few companies got rich, or it became useful. But I would suspect, because the technology is changing so much, that we'll be able to get around it one way or the other, and that they won't be a necessary thing. You wouldn't have to feel like you have to do that.
I think I'm going to take this opportunity to bring something up that I can't believe Peggy hasn't pushed me on. But one of the things I just wanted you to be aware that when you come to our clinic, we do ask whether you'd be interested in participating in our research. And one of those aspects is to allow us to compare your buttocks to Bob's.
Buttock to buttock.
And actually to let us take a very tiny skin punch biopsy, which basically causes about a freckled, about 3 millimeter punch biopsy that leaves a little bit of a freckle. We've done this in the vitamin C trial that Carly and I and Mike Shai were involved in. We did punch biopsies twice, once before they took the vitamin C or the placebo, and once after. So it's quite doable. It's very safe. People don't want it. We don't force you into do it. We don't chase you down the hall. But we do, and we also sometimes will take some blood for DNA samples for research purposes. So I just want you to be aware that we can use your cells, and Bob then plays with them in his lab to develop the iPS cells. Okay. Pat, do you have others?
I've got one more.
Okay.
It says, what's being done to enlighten other medical professionals as to what CMT is? For example, it's really frustrating when a patient needs to explain what CMT is to the physician. I think everyone's, by the reaction, has probably had that as an experience. So I know the CMTA, through Dr. Shai and Dr. Scheer, and maybe you were part of it, has put on their website approved specialists that understand CMT as a disease, and you can plug in on a state-by-state basis and see where the nearest one is for you. Short of that, it is an issue, all the way from, I think, Dr. Pfeiffer, who said that, it was in his medical book for 5 seconds, and then, we forgot about it, or it wasn't, taught further. So, we have to do a lot of work on that side, but there's nothing that, if you do know you have CMT and you're visiting a doctor, we have all the pamphlets of what is CMT and what we do. Bring it with you. Just like when you go through the airport, we have special cards that will give you special treatment to help you go through the TSA lines, et cetera, et cetera. So we're working on the education part, but I think when patients come see anyone here at the clinic, I'm sure they've heard the story over and over again. It's probably their 5th or 6th stop in trying to tackle a disease that not many people know about.
Yeah, just to follow up on that, because someone asked about, are doctors learning about CMT in medical school, and how do doctors get notified about new breakthroughs in CMT research? Medical school curriculum has a lot of stuff to go through in a few years, and CMT is probably mentioned somewhere in those first 2 years of neurology, but it's in the middle of Alzheimer's disease and stroke and Parkinson's and a whole bunch of things. No one's spending an hour going over CMT, and even if they spent an hour, how much would they retain if they don't see patients with it in their practice? I see a lot of patients in my practice with it, and neurologists end up seeing patients with it, and foot surgeons do, but not the GI doctor. They may, but not, it would be by accident. So in neurology, we certainly, people that come through our program, and I'm sure through Dr. Day's program, they're seeing CMT patients, and if they're not seeing them, I'm talking about it, and Dr. Day's talking about it, and Dr. Balo's talking about it. So the residents, the neurology residents, and some of the medical students get that exposure. But there are lots of diseases, and no doctor can know a lot about all of them. Same thing about the breakthroughs. I look for them. Dr. Day looks for them. Dr. Balo's reading about them all the time. But people who are not in the field are not going to be looking at it. But the nice thing about the web is if they have a patient, they can do their homework and look at it, or they can say, this isn't for me, I'm going to send you somewhere where someone can do this for you, and that's where the CMT centers come in. So, let me see if I can you reach for your?
Sure. So I have a really important question about bullying. How do you handle bullying when your child is being bullied, and what words do you give your child to stand up for themselves? I think bullying is a really, really important issue, and it's gotten actually a lot of a national attention over the last couple of years. First of all, I was talking to Elizabeth, and Gina was talking about the programs that they've been doing in their schools for awareness, and I think that's a really important place to start. That I think bullying isn't an individual issue, it's really a larger issue than that, and I think bringing it to the school's attention, involving the school in working with it as an entire group is very important. Making kids aware both about CMT but also about the idea of bullying, that it's not something that a child or a family should have to handle on their own. Secondly, I think there's a lot of really very good specific information on the web in terms of bullying because it's gotten such national attention that would really address this in a more in-depth way. And thirdly, I think really if your child is telling you about it, I think it's a good sign. It means that they're trusting you, that they're not holding it inside, to be able to talk with them about what that experience is like, to come up with plans together, having clear in your mind that there is action that can be taken, I think is very important so that they're not alone in it. And talking with them about what the kids are saying and really giving them a sense that it is the problem of the other kids, that it's a problem that they have about bullying and about bad feelings within themselves, that they're a scapegoat in a sense, and CMT, if it's about the CMT, is a scapegoat in that way. I think all of those things are important first steps.
Yeah.
So it's a great question, and it's something near and dear to my heart because the other part of the reason I joined the CMTA is so kids don't have to experience this disease, and as long as I can do anything about it, I will. But Gina's program and Elizabeth's CD together, in an indirect way, without saying the word bully, teaches how a person is different in the school. And there shouldn't be a principal out there in America that wouldn't welcome it, especially if it's one student in their class. They should know about the bullying. But ask them and take a proactive step and say, we'd like to put on in the auditorium with the classes a 45-minute teaching, which is a lot of fun because Jean is a lot of fun and she involves everyone, et cetera. But at the end of the time, not only is the ignorant kids, and kids are brutal. They're not, anything but brutal, as far as growing up. We were all kids, heck. And I remember when, kids were called baggy pants Biff, and that was a big thing. And, so there's bullying been around since time, but this is different. I mean, this kid doesn't have CMT because of anything he did or did wrong or deviantly. It's something he's born with. And we have found success when we teach in just 45 minutes that the rest of the class not only understands it better, but really feels bad, and it changes it. Elizabeth's son is a perfect example. His whole life changed when Elizabeth went into that school and taught. And using socks on hands to try to button a shirt. You know, being pressured to move out the door when you can't walk too quickly or through a fire drill. I mean, things like that, which makes it fun, but man, is it poignant, and these kids get it, because kids usually are really good, you know, people if they're taught, so.
Yes, because your book needs to be distributed to the schools. Mm-hmm.
We're working on information that would be like a quick fact sheet to give to teachers at the beginning of the year. And then I just wanted to add too, because bullying is a huge problem and I'm teaching right now, empowering other kids to not be innocent bystanders and watch, but actually to speak up has been a huge way to get bullying decreased in my school, and that's been very helpful too.
Thank you. So I'm going to have a series of questions about medications and treatments. So I'll go through them relatively quickly. I use Advil to treat some of my pains. Any comments about over-the-counter medications? My comments are that sometimes non-steroidals help, and other medications can help certain pains, joint pains, and even the muscular pains, and occasionally people find it helps some cramps. The only thing I would say about over-the-counter medications is that you should let your doctor know, your primary care doctor know, that you're taking them. That those are medicines. They're not, just because they're not prescribed, they're medicines. And taking a lot of Advil, like 10 pills a day, may not be good for your kidneys and other organs. And if you think that that's not a medicine, your doctor doesn't know you're taking it, he can't advise you about the appropriate use of those medicines. The second part of this question is, I find having an alcoholic drink at bedtime reduces leg and foot cramps, muscle spasms, and other symptoms. I think we should go to the bar and talk about that in a few minutes. Yes. I will. Yeah, and the use of medical marijuana is an interesting point, and not, not necessarily, it has some significance. Many patients find it's very helpful to them. I'm not pushing it. That's not my second job, but if you're really having troubles figuring out how to get comfortable, that may be an appropriate thing to consider. The CMTA medical alert, I think, mentioned some multivitamins and statins. And is it okay to take vitamins with pyridoxine? Pyridoxine, there's a little bit of a literature that says excessive amounts of pyridoxine can cause neuropathy. It's being questioned a little bit now. My personal belief is if you're taking one-a-day vitamin, you're not going to have any troubles. If you're starting to do megavitamins, that can cause potential problems in a lot of different ways, and there's really no evidence that megavitamins do anything for anything, except maybe give you diarrhea. So I would be a little careful about doing those things. Statins...
Pyridoxine is vitamin B6, just
right.
for those who didn't know.
I'm sorry. They actually said pyridoxine here, so, but it's vitamin B6. Statins also has somewhat of a controversial role in neuropathy. We know it causes muscle problems, but not in a small number of patients, but a significant number of patients, given the number of people taking statins. There was some question whether it caused neuropathy. Probably doesn't, and I'm not aware that it's contraindicated in CMT. If you need it for your cholesterol, you need it for your cholesterol. Some of the other medications on the alert, there are some things that if you look up the data on some of these things, there's not a lot of data on many of them, whether they do much or not. Vincristine and probably some of the other chemotherapy agents is a potential big issue. And so I definitely think you need to let your oncologist know about your CMT, and they probably should work with your neurologist about that. And clearly, vincristin, if they can treat you, and they can treat lymphomas now without vincristin, that may be an appropriate thing to do. What else? Are there drugs, or I'm not sure I have this, or actions, I guess, to take to reduce fatigue and reduce weight? Weight, I'm not a big proponent of medications to reduce weight. Reducing weight is basically a balance between burning calories and taking them in. And unfortunately, it's sometimes hard for some patients with CMT to burn as many calories as they would like. So there may be an adjustment in diet. But clearly, as we've been saying all along, we want you to be as active as you can be. And the more active you are, the more you can eat. And you just need to be very careful about your diet. But I certainly don't think medications for that is necessarily the right thing to do. Fatigue's a very confusing problem, because what one person means about fatigue is not the same as another. So one of the things I would strongly recommend, if you have daytime fatigue and it's sleepiness, think about whether you have a sleep disorder, because that you can fix in the middle of the night with CPAP or whatever other things. If it's muscle fatigue and that, then there's an issue, but that may not be so easily treated by medications. So unless you have really excessive fatigue, I'm not sure that you want stimulants to start dealing with that issue. So I don't know, Bob, if you have any other thoughts. I'll do one quickie and then I'll turn the mic over. Someone asked, is there any evidence that a virus could be impacting CMT? It doesn't cause CMT. If you have a virus that attacks your nerve, then you have a double whammy. But in general, there's nothing specific about CMT that makes viruses better or worse. So, okay. Glenn, do you have? Nothing. You're good? Bob? Or Bethany? Anyone?
Sure, there's a couple here that are sort of related.
I'm sorry, did you have all this?
So one is that can we replace or transplant damaged nerves with good nerves? So it's an interesting question. There are actually some disease states, particularly trauma to nerves or others, where you can take a piece of a good nerve and transplant it over to the other nerve that's been damaged. The problem is that actually when you do that, the nerve has to then, from the proximal side, from the side closest to the spinal cord, grow back through the graft. And so in a person who has normal nerves, that can be accomplished, but it doesn't work extremely well. They don't always go to the right place again. They actually can't quite find the right spot, and so you can have some weird problems that come from that. You activate muscles you didn't think you were going to activate, and it doesn't work very well. So in CMT, the likelihood that it would work is even worse because the ability of those axons to grow back might be compromised. So it can be done, but it's probably not an ideal approach. Ideally, we keep those axons intact, these connections between the spinal cord and the muscle, or the skin and the spinal cord, from the beginning, and don't let them get damaged. Because if they do, regardless, the challenge of getting them to grow back to the right spot is always another additional problem that we have to figure out. The other question was, is there really no hope for regenerating muscle once it's gone? And so I guess that's the answer is really, muscle shrinks as a consequence of the nerve going into the muscle being damaged. And the muscle basically initially sits around and waits. And it thinks that it's going to be reinnervated. And that's because normally when you were, fighting off a jaguar and you got a little nerve injury and then you killed the jaguar, and then the nerve would grow back. So the muscle will stick around for a while, and it will actually wait for that nerve to come back. And then if it does, it will grow back. The muscle will actually regain its bulk. But it can only wait so long. And in CMT, the nerve is dying back, and the muscle sits there for a while. We see that electrically it gives off these signals that are saying, hey, I'm waiting for somebody to come and rescue me. But if it sits there long enough, it actually does probably shrink down to a point that we don't know whether it would grow back. The muscle is still there, but it will turn eventually into completely fibrous tissue and fat. And it's unlikely at that point it would grow back. That doesn't mean that, again, you couldn't come with regenerative strategies and try and grow back the muscle at the same time you could a nerve. It's not like there's no theoretically way to deal with that. But it does add additional problems, that once a muscle's been denervated long enough, it'll be hard to get it to grow back. We'll have to figure that out as another solution.
Great. Tara, you have one.
So someone was asking about the type of samples that could be used for genetic testing and whether or not hair could be used. I'm not aware of any genetic testing lab that receives a hair sample. I know GeneDx is here. Carly, are you aware of anybody? And it has to do with the quantity of DNA that we can get from these things. We do, and some labs will take a saliva sample or a cheek swab, but blood really gives us the best source of DNA. We have to take the sample that you get, and then the lab has to extract DNA from the sample, and we get the greatest quantity of DNA from a blood sample.
Pat, do you have any others? Or okay.
Can I add on to that? Just
Yes, go
if
ahead.
you really are afraid of needles, and the only thing between you and giving a DNA sample is a needle, then we can take saliva. Because there are just a few people who that's a deal breaker, and we understand. So we actually can take saliva for some of the DNA studies, but it's not quite as good. So we do prefer to get DNA from blood. That's what I'm saying.
I have a few more here since we have 3 minutes. We have 5 minutes, and I have 5 cards. So I think we're good. One question is it possible for things like massage or acupuncture to slow down the progression of I assume, the disease by stimulating the nerves? Massage is good in many ways. Many of you probably get massages and like them, and it's probably good for tight muscles and other things, but it will not slow the disease down and doesn't really stimulate the nerves. There was a question about, does CMT make an otherwise good candidate for knee replacement not a good one? I.e., would the weakened muscles jeopardize the chances likelihood of a successful recovery? So I'm going to turn some of that to Glenn, see what his thoughts are. But as far as I know, we've had a number of CMT. Anyone here has had a knee replacement with CMT? Any problems? Nope. Nope. Yup. I have a yup and a nope. So in general, if you have CMT, if you're in bed for a long time, in a recuperation, it's going to be a slower recovery. The weakened muscles are, it just takes longer to get back up on your feet and walk. So recovery, I think you should at least think that your recovery may not be as smooth as the surgeon thought it would be for someone who doesn't have CMT. But whether it should, in fact, have a long-term issue, I don't think so. Whether the knee replacement would take well, I think should not be an issue. I think it's just a matter of, you may just expect that there may be a prolonged recuperation, but that doesn't mean you shouldn't fully recuperate. Is that fair, Glenn?
Yeah, I talked to someone about this before. I think that's completely fair. Where it would be more concerning is someone with an advanced CMT and who has involvement proximally, if they're having a total hip and they don't have good musculature to keep the hip in place, you'll be prone to dislocation. The hip should be done in a special way and by someone who understands CMT. But I'm not as concerned about the knee.
Yeah, but I guess if the quadriceps was significantly weak, then that might be an issue with the knee replacement.
You just have to make sure not to get worse by getting adequate therapy. Having the knee itself shouldn't cause the CMT or the muscle weakness to progress.
I mentioned briefly about the question about scoliosis. The only thing I would say is if your child has scoliosis, it really should be at least looked at and followed. We have Matt Bernstein who's a pediatric orthopedic surgeon who sees some of our children with CMT who have scoliosis. It certainly should be looked at, followed, and appropriately treated. You do not want to allow a severe curvature if you can avoid it. Environmental factors. Are there studies to look at environmental factors that may affect CMT, such as artificial sweeteners, plant-based diets, and a number of other things? I don't know of the studies. And environmental factors are very difficult things to get a handle on. I'm not aware of artificial sweeteners being an issue in CMT. I think, slightly pertinent to what Lynn was talking about, there is a tendency, not just in CMT, but in anyone who has a chronic disease, to look for something that you can say is going to make a difference or is the cause or something. A little bit of it's okay. If you're doing it all the time and starting to blame all kinds of stuff on things that are happening to you, it may not be as healthy for you in the long run. So it's very hard to know about the environmental factors, but as far as I know, no one has ever shown any specific environmental factor. And I think the last question, some of you who saw us at Wayne State were involved in the North American database. And so the question here is the Rare Disease Network and the North American, what's the difference between them? Carly probably has a better handle on this than I do, since she was very much involved in both. They are different, but how are we using the North American database at this point? So the people who had information in the North American database, I think you still need to basically give approval to be part of the registry from the clinical research part. The patient contact registry that I mentioned that you can do whether you see us or not, I don't think that's a permission thing. But as far as I know, I don't think there's an overlap, I guess, with the North American database. But again, we have 4,400 patients in the current registry, which I suspect is a lot better than we had in the North American database. So I think we've captured a lot of that.
Well, I want to give a big round of applause for our panel. Thank you so much for answering our questions.